Okay, well, I'm grateful to have been asked here to give the presentation today. As Chetal said, I'm Dr. Helen Neighbour. I am a clinician. I'm a respirologist at St. Joe's in the Firestone. I also do general internal medicine, and I'm on call today. I have signed my pager over, but pagers don't always listen, so if my pager goes off, I apologise in advance. I also do a lot of research into new treatments for allergic disease and asthma. The only real conflicts to declare is that the peptide product that we'll be talking about today, I have received funding to conduct a study into that, but otherwise no relevant disclosures. So really your learning objectives today are to understand the clinical effects of allergic disease and to understand why we need new treatments for allergic disease. Dr. Lachey will then go on to explain how to understand how the immune system tolerates some proteins but reacts to others, which causes allergic disease, and to appreciate how we can develop new treatments recognizing these proteins and inducing tolerance with the ultimate aim of curing allergic disease. So what is allergic disease? I'm sure everybody's got their own idea of what constitutes allergic disease. Essentially, it's the result of an exaggerated, inappropriate response of the immune system to external substances. And this can be various things from the house dust mite to animals to pollens, peanuts or penicillin. So all very different proteins, but all of them trigger allergic disease. The three common allergic diseases that we talk about are rhinitis and sinusitis, asthma, and eczema or allergic dermatitis. I'm not going to talk about allergic dermatitis here today because it's not a disease that I study in depth, but just bear in mind that that does fall under the scope of allergic diseases. Rhinitis and sinusitis, I'm sure you're all familiar with the symptoms of that. Sneezing, itchy nose, rhinorrhea, which means a watery discharge constantly running from the nose, and also nasal obstruction. And this is really quite unpleasant for patients to have to suffer. The gentleman with his nose pointing at us, I don't know if you can appreciate in his left nostril, there's a red swelling. That's a nasal polyp coming down, which is a mass of inflammatory allergic tissue. And it's completely occluding his nostril. And if they don't get removed, they actually can grow outside of the nasal cavity, which fortunately happens very rarely because people seek medical advice, but they often require frequent surgeries. The picture with the stranding across it, that's a speculum put up the nostril, and you can see the white streaks. That's the inflammatory exudate across the nasal mucosa. That nasal mucosa should be nice and flat and pink, but you can see that it's all raised with bumps and is swollen, and that's rhinitis. The cross-sectional CAT scan, it's a bit difficult to point things out in here, but I will just show you. So these round things here are the eyes. This patient's been cut through the head this way by the CT scan. These are the sinuses. They should be black and full of air, and these are the sinuses at the front of your head, and these are the sinuses underneath your maxilla. These should be full of air, but they're completely full of inflammatory exudate. And you can see this patient's going to have symptoms of facial pain, recurrent infections because they can't drain their secretions. And this is quite a big problem for patients. Asthma. Asthma is a disease of intermittent narrowing of the airways. I know you've had talks by Dr. O'Byrne, so I won't cover asthma in too much detail because you know about that. But symptoms are that of wheezing, shortness of breath, and cough. And again, these symptoms are quite limiting for patients. So just a brief history of allergic disease. These two physicians really were the key in driving the development of allergic disease as a specialty. They were both Englishmen. Dr. Lachey and myself are English, but I'm not saying that the English do allergy particularly well, but there seems to be a bit of a theme running here. John Bostock, he described a case of periodic affectation of the eyes and chest. That was the paper he published. Sorry, that's 1846. He wasn't some hugely long-lived person, 1846. And he described what essentially we know today as hay fever. So he described patients who in the summer months had this eyes and chest disease, and he didn't really understand what was causing it, but noted that there was definitely a seasonal pattern to the disease. Blackley really was the key to understanding what was going on with allergic disease. He published a paper called Catarrhus estivaz, which means summer flu or summer cold. And again, he was noting the seasonal variation and the summer onset of symptoms. And he was very interesting in that he himself was allergic to grass. And he was at a friend's house in their lobby, and they had a big dried plant arrangement with some dried grasses in it. And he actually had some scratches on his arm, and as he was on the way out, his arm caught this grass flower arrangement, and his arm swelled up in the lines where the cut was. And then he sort of realized, well, maybe, you know, it's something in the grass pollen that's out in the summer that's causing my symptoms, and that's really where skin prick testing was developed. And he went on to do other studies that determined pollen, and he had a great research project that involved flying kites. So he actually used to put microscope slides on kites and fly them, and then he used to bring them down and count the pollen grains on the slides. And he worked out that the days where there was more pollen were the days when his own symptoms were worse. So he was the first person really to make the link with an allergen. So really the scale of the problem, you might say, compared to things like cancer or multiple sclerosis, you know, a bit of sneezing, is it really a problem? And obviously, from my point of view, the answer is yes, but, you know, as a worldwide problem, it is a huge, huge issue. Over 500 million patients worldwide suffer with allergic rhinitis, which is a huge problem. There's a lot of loss of productivity, and the economical costs from that are actually quite significant. The other thing is, because of the timing of people with hay fever being in the summer months, there have been studies that have shown people with hay fever actually do worse in the exams because they're not feeling well, and also they have to take medications to control their symptoms that affect performance, and that's been well documented. The association between rhinitis and asthma is also well known. Rhinitis worsens associated asthma, so it's important that that's kept under control. And just to put it in a local perspective, asthma affects 2.5 million Canadians, which is a lot of people when you're talking about loss of productivity, exam results, and generalized quality of life and ill health. So this is looking at the changes in the prevalence of asthma that was diagnosed, and also asthma symptoms over time across a variety of countries in children and young adults. And I think you can see that in all countries, this is increasing over time. So it's not a problem that's likely to go away. It's a problem that is real, and a problem that's only getting worse. So really should be a target of new treatments. And again, this is just the epidemiology of asthma within Canada. So the prevalence has been increased over the past 20 years and is really one of the highest in the world in Canada. Some of this can be attributed to increased diagnosis, but certainly not all of this can be attributable to increased better diagnosis of asthma. This really is a true increase in the disease. And at least 12% of children have asthma. So as I'm sure you've heard in your other seminars, asthma control is very important, and children who have poorly controlled asthma miss school and don't do as well and miss out on sporting activities. So control of asthma is very, very important. I'm just going to talk a little bit about the basic mechanisms of allergic disease, but not cover that in too much detail, because Dr. Larche is going to cover the more basic science side of things. So it's an antigen, which is a protein, an allergen, which gets recognized by the immune system on these antigen-presenting cells. And then the individual makes an IgE antibody, so a type of antibody specific to the allergic or infection response. And these IgE then bind to receptors on mast cells. When the patient gets exposed again to the same protein, these IgE molecules link together. They're linked together by receptors on the protein and the IgE, and the mast cell degranulates. They then release histamine among other mediators, and I'm sure you're all familiar with the effects of histamine, the itching, redness, and swelling. And that really causes the early phase. Dr. Larcher is going to talk more about T cells, and T cells are really involved in the generation of the late phase of the allergic response. And this is just a schematic of how the allergic response works. So in the top panel, you can see the allergen being put onto the dendritic cell, which is the purple cell with lots of spicules coming out of it. This then gets presented to a B cell, which makes the IgE. The IgE then binds to the mast cell, which is the bottom panel there, and the allergen fits on top again, and the mast cell degranulates. The late reaction is a bit more complex, and again, Dr. Larcher will cover that, but basically T cells get amplified through ongoing allergen exposure and promote the recruitment of eosinophils. And this is just a schematic of what happens when you give allergen inhalation to an asthmatic. So the y-axis is the FEV1, which is a measure of their breathing. So their breathing is at 100% before you start. You get them to breathe in some allergen, and they're breathing the FEV1, their lung function starts to fall really within the first hour, and that's called the early response. A subgroup of patients then get better for a while, and then between 4 to 8 hours, their lung function starts to fall off again, and that's the late phase response. So how do we test for allergic disease? How do we tell if somebody is allergic? We can use skin prick testing, and that's what that person with their arm has had done. So we have allergen extracts in glycerin in little droppers, and we put it all up the patient's arm. All the various panel, we have grasses and tree pollen, cat, dog, molds, a panel of allergens, and then we have a very fine little needle, and we literally just flick, so we break the epidermis so that the allergen gets in. And you can see this patient's got raised lumps. That's a histamine response to the allergen. The mast cells have degranulated. And that's a wheal and flare response, because you can see there's a red flare around it. So that patient is allergic to whatever allergens they've had put on them. If you're not allergic, nothing happens. The middle panel is a nebulizer. The last page I just showed you was of the early and late phase response, and this is the equipment they would use to do that. So again, they put an extract of the allergen, which has been very carefully calculated based on their skin prick test result to see how allergic they are. And then they inhale that allergen, and then their lung function gets monitored. And the last panel is a nasal spray. So we can put the allergen extract in a nasal spray. They're disposable. We can put whichever dose we want of the allergen in there, and we spray it up the patient's nose, and then we measure nasal obstruction and symptom scores following the allergen exposure to determine if they're allergic. We can also now measure serum allergic specific IgE, so we can actually measure whether the patient has IgE against the antigen we are looking for. CAT scans do not work for allergen. I showed you a CAT scan earlier of a patient with sinusitis, but these aren't the type of CAT scans we talk about when we're talking about cat allergy. So what treatments are currently available for the treatment of allergic disease? Allergen avoidance. My favorite one, my patient's least favorite one. Allergen avoidance is easy, really. It doesn't really come with too many side effects apart from the potential emotional ones, which my patients seem to have the biggest problem with. Obviously, if you're allergic to cats and you've got a cat, the first thing I say is you need to remove yourself from the allergen, and that can sometimes be a problem. Things like dust mite, it's more difficult to avoid the allergens. Lots of studies have shown that most things to avoid dust mite really don't work, and obviously the pollens, it's impossible really to avoid the allergen because it's just seasonal. There are simple things that the patient can do, such as wearing wraparound sunglasses to prevent the pollen getting in their eyes, keeping their bedroom windows closed in the evening because the pollens come out in the warm evening, drift through the window, settle on their pillow, and then they have 8 hours of an allergen challenge. So there are some simple things to do, but often when there's animals involved, there's a problem. Antihistamines, I'm sure you're all familiar with these. You can buy them over the counter. They aimed at the early response. Corticosteroids are general treatment for most things. They wipe out allergic responses. They are very effective, but they come with quite significant side effects such as diabetes, cataracts, osteoporosis. So they're not an ideal treatment long term. Bronchodilators obviously work for the treatment of asthma. And chromoglycate eye drops for the treatment of eye symptoms also work. So then we move on to immunotherapy, which is another treatment for allergic disease. And basically, this is the repeated administration of low doses of allergen to which the individual is sensitized in a stepwise incremental pattern. So basically, it's again, the extracts I spoke about, for example, cat, you get cat extract and start at a very low dose and inject into the skin increasing doses of this, and it induces tolerance in the patient. But it does require frequent doctor's office visits, and you have to stay in the office as well afterwards because there are risks of severe allergic reactions. Some oral forms are now available for grass pollen, but overall compliance with this therapy is poor, mainly because of the number of visits required, and also because of the time you have to spend in the doctor's office. So this is a study from Holland where they were looking at compliance of immunotherapy. SCIT is subcutaneous immunotherapy, which is injections under the skin, and the SLIT is sublingual immunotherapy, which is the oral form. And so the duration of therapy is 3 years, so you can see why there would be an issue with compliance. And only 18% overall achieved compliance. So you can see compliance with general conventional immunotherapy is extremely poor. So what is an ideal therapy? When you're designing a therapy for any drug, what do you want that drug to be like? Obviously, the biggest thing is you want it to be safe. That's got to be number one. You want it to be effective. You want it to treat what you want it to treat. Low side effect profile, which comes linked into it's got to be acceptable to the patients for them to take. Limited need for compliance. So again, if they have to take it 6 times a day, it's not going to happen. And it's also got to be cost effective for it to be an ideal therapy. So I'm just going to introduce the concept of clinical trials. What is a clinical trial? So it's a prospective study. It's a study going forward investigating something, and they always have a specific question, a hypothesis, which they want to answer. And talking about when we're talking about clinical trials of drugs, the specific question is either efficacy, does this drug work for the condition we propose? Is it safe? Can it be given to people? Or it can also just answer the question of mechanism as to how this drug is working. And they come in varying phases, described as phase 1 to phase 4. Phase 1 is first time into human, which is looking at safety data. So all the animal work has been done, but it's never been given to humans. So that's a phase 1 study. Phase 2 is where it's proven to be safe and it's first time into disease, where you're looking at its efficacy. Phase 3 is a slightly bigger study, so if it works in phase 2 in a smaller group of patients, you take it into phase 3, which is a larger number of patients with disease, looking at efficacy. And phase 4 is post-marketing, so the drug's been proved to be effective and safe, it's gone on general release, and phase 4 is collecting the data after it's been used on a large scale to make sure that it is as safe as we think it is and is still effective. So I'm just going to introduce our patient by way of talking about a cat peptide therapy trial that I was involved in. So this was a phase 2 study, so all the safety data had been done, and it was first time into disease, so patients with allergies. But this study was a mechanistic study. The question was, how does peptide therapy work, specifically looking at effects on gene expression. The subjects in this study were allergic to cats, and they also had ongoing exposure to cats. They received 4 injections of peptide therapy, and these injections were given 4 weeks apart. We didn't specifically collect any clinical outcomes because the study wasn't powered to determine that. We only had 10 patients because we were looking at gene expression, so I don't have clinical outcome data for this study. But don't take my word for it. We'll ask Leanne to come up, and we'll ask her some questions about what it was like to take part in a trial and how she found the study. Have a seat. So this is Leanne. She's very kindly come in today. So how long have you had allergies?
My entire life. I'm 31, so since I was born.
Okay. What are you allergic to?
Cats, dust mite, grass, birch, and a few drugs.
Okay. Do you limit your exposure to cats?
No. I own one, so I've never limited my exposure to cats.
Okay. Have you ever thought about limiting your exposure to cats?
No.
Okay.
No. I'll be honest.
No, I mean,
No.
This is an ongoing problem in clinical practice. And what treatments have you tried for your allergies in the past?
Oh, everything. All the different pills on the market. I had to rotate them every couple of years because I grow tolerant to them. I had sinus inhalers. I had asthma too as a kid, so I had the bronchodilators. I've used eye drops. I've used everything.
Okay.
Everything available through a pharmacy.
Okay. Do they work?
Short term, I ended up taking 3 or 4 of the antihistamine pills a day.
Okay.
So,
did the treatments themselves cause you any problems?
inconvenience. That was the biggest one, because if you forgot to take them, you were in trouble, and you had to take them a couple times a day. So inconvenience.
Expensive?
And cost.
Yeah.
Cost was insane. Flovent alone was, I don't even want to go there.
Okay. If you could design your own treatment for allergic disease, what would be your ideal treatment?
Long-term effect, minimal commitment, and cost-effective.
Okay. She was paying attention to my slide.
No, hey, I came up with that on my own. I studied.
So how did you hear about our clinical trial that we were doing?
I had gone to my GP and asked to see an allergist I live in Brantford, in town, because my allergies last summer were out of control. I could barely even see when I drove. And she suggested that I get the allergy injections, and when I kind of pulled back on that because it is a commitment, she had suggested that I contact Dr. Neighbour for this study because I would probably be an eligible patient, and she was right.
So what made you finally contact us?
Frustration. I wanted something to change. I mean, like I said, I was taking 3 or 4 antihistamines a day, and I can't live like that.
Okay. And was taking part in a trial what you expected it to be?
It was better.
In what way?
It was organized. It wasn't, I don't even know how to put that into the right words. It just seemed like a regular doctor's appointment. It didn't seem like it was a study per se.
Okay. Did you have any problems during the study?
No, none.
No? Okay. Did the injections hurt?
Oh, no. No, I like this version of injection.
Okay. Have you noticed any difference in your allergies after the study?
Yes, I have none. Yay.
Okay.
None.
And would you take part in a trial again?
Absolutely. Absolutely.
Okay, so that's the end of the patient interview. Hand over to Dr. Larche.
Excellent.